The American Cancer Society estimates that in 2025, approximately 21,000 women will receive a new diagnosis of ovarian cancer, and approximately 12,730 women will pass away from the disease. Ovarian cancer is one of the leading causes of cancer deaths among women. A woman's risk of getting ovarian cancer during her lifetime is about 1 in 91. Her lifetime chance of dying from ovarian cancer is about 1 in 143. This cancer mainly develops in older women. About half of the women who are diagnosed with ovarian cancer are 63 years or older. Historically, ovarian cancer was thought to originate in the ovary. However, we now know most ovarian cancers actually originate in the fallopian tubes. Recent studies show that high-grade serous ovarian cancers begin in the far end of the fallopian tube, especially the fimbriae, which are the finger-like projections at the end of the fallopian tube closest to the ovary. The term serous refers to serum-like because these tumors often produce clear or watery fluid. Women with BRCA1 or BRCA2 mutations are especially at risk. Studies of prophylactic salpingo-oophorectomy, which is the removal of both the ovaries and fallopian tubes, demonstrated early precancerous or cancerous lesions in the fallopian tubes but not in the ovaries, further supporting the concept that ovarian cancer originates in the fallopian tubes. Removing only the fallopian tubes, which is called salpingectomy, eliminates the site where most ovarian cancers typically develop. Studies have shown that women who undergo just salpingectomy have a significantly lower risk of developing ovarian cancer. It is estimated that 80 to 90% of BRCA-related ovarian cancers originate in the fallopian tube. Removal of the fallopian tubes, salpingectomy, may be a viable option in ovarian cancer prevention to avoid the severe adverse effects of removing both ovaries, called oophorectomy, which results in early menopause and infertility. Histopathologic analysis, which is the study of diseased tissue of the reproductive area that had been removed during surgery from BRCA-positive women, revealed that 4 to 17% had a cancerous lesion. 57 to 100% of those cases were found in the far end of the fallopian tubes, the fimbriae. This pathology is termed serous tick or stick. This lesion is found in almost 60% of patients with ovarian cancer, which indicates that the majority of cases are actually of tubal origin. Performing only salpingectomy in BRCA-positive women may reduce the likelihood of having ovarian cancer to the same degree as a complete salpingo-oophorectomy, which is the removal of both the ovaries and the fallopian tubes. But it also means the loss of fertility and the immediate onset of menopause. This more conservative approach, only salpingectomy, comes with a lower risk of long-term complications from surgical menopause. Additionally, for young patients who wish to undergo prophylactic surgery, salpingectomy alone may provide more time to conceive via in vitro fertilization. Complete salpingectomy or removal of the whole fallopian tube is preferred compared with fimbriectomy, which is removing just the fimbriae, even though BRCA-associated tubal lesions were most often found in the distal or far end portion of the fallopian tube, the fimbriae. Therefore, salpingectomy alone or delayed oophorectomy can be a viable choice for young BRCA-positive patients to maintain fertility using in vitro fertilization and avoid premature menopause.